Welcome to this explainer. Today, we're opening up the detective's toolkit for the bedside cardiovascular exam. We spend so much of our time these days just staring at screens, but today, we're going to decode the heart's hidden physiological puzzles using nothing but our hands, our eyes, and a stethoscope.
It sounds almost impossible, doesn't it? In an era where we can instantly order an echocardiogram or an MRI, can you really diagnose a complex heart defect without a single machine? Well, the answer, incredibly, is yes. The findings from a careful history and physical exam can actually establish the presence, the severity, and the prognosis of several major cardiovascular diseases. Before the results of any biomarker testing or advanced imaging are even known, the clues are already right there. They're literally written in the pulses of the neck and the sounds echoing through the chest.
Okay, let's dive into this. Our very first major clue isn't actually found on the chest at all. It's right up in the neck. The jugular venous pulse, or JVP, is our direct, literal window into the pressure dynamics of the right heart. By just looking at the internal jugular vein, we're essentially looking at a continuous column of blood that connects straight down into the right atrium. It's absolutely the single most important bedside measurement we have to estimate a patient's volume status.
Now, what's really wild is how a single, ordinary heartbeat breaks down into this highly detailed pressure diary. The JVP isn't just a simple pulse, it's a complex waveform full of distinct peaks and valleys. First up, you've got the A wave. That's the right atrium, actively contracting right before ventricular systole. Next is the C wave, which happens when the tricuspid valve snaps shut and actually bulges backward a bit into the atrium. After that, the pressure drops, creating what we call the X descent. Now, while the ventricle is busy squeezing, the atrium is quietly refilling, building that pressure right back up, and that gives us the V wave. Finally, the tricuspid valve opens up, blood dumps into the right ventricle, and we see the Y descent. So every single little bump is telling us exactly what the mechanics of the right heart are doing in real time. It's like a live broadcast.
And this mechanical diary becomes even more revealing when we ask the patient to just take a deep breath. Under normal physiology, breathing in creates negative pressure in the chest, right? And that pulls blood into the right side of the heart. Because of that, the jugular venous pressure should normally drop by at least 3 millimeters of mercury. But in what's known as Kussmaul's sign, this whole standard physiology just flips. The JVP actually rises, or at least fails to fall, during inspiration. This is a massive red flag. It tells us the right ventricle is so stiff or restricted, like you might see in a condition like constrictive pericarditis, that it simply cannot accept that extra blood volume. So what happens? The blood has nowhere to go, and it backs up right into the neck.
All right, let's move our investigation down from the neck and into the chest, specifically looking at the internal chambers and valves of the heart. Think of the thick muscular walls of the ventricles and those delicate parachute-like structures of the atrioventricular valves, held firmly in place by their chordae tendineae. This is the anatomical theater where our next set of clues is going to emerge. You see, when blood flows smoothly through these chambers, it's virtually silent. But when there's turbulence, or when these highly precise valves snap shut, that's exactly what generates our classic heart sounds.
Which brings us to what we might call the symphony of the second heart sound, or S2. While the first heart sound, S1, is the closure of the mitral and tricuspid valves, marking the start of a heartbeat, S2 marks the very end of ventricular systole. This is the exact moment those semilunar valves, the aortic and the pulmonic valves, snap shut to stop blood from washing backward into the heart. Normally, it's just a crisp, high-frequency sound, but if you listen really, really closely, it holds a fascinating secret.
And this brilliantly illustrates the real secret of S2. It's actually two completely separate sounds that can split apart just based on breathing. During expiration, the aortic valve and the pulmonic valve close at almost the exact same millisecond. That gives us a single sharp sound. But when a patient takes a breath in, inspiration, that negative chest pressure we were just talking about draws extra blood into the right ventricle. And because there's suddenly more blood to pump out, the right ventricle takes just a tiny fraction of a second longer to empty, delaying the closure of the pulmonic valve. So the sound literally splits into A2 then P2. This physiologic splitting is an absolute hallmark of a healthy, dynamically responsive heart.
Now we reach the absolute climax of the bedside examination, dynamic auscultation. We aren't just going to sit back and passively listen to the heart, we are going to interrogate it. By having the patient perform very specific physical movements, we can intentionally alter the hemodynamics, meaning the volume and pressure of the blood, to basically force hidden murmurs to reveal their true identities. It's essentially a physiological stress test performed right there at the bedside.
To really get how this works, we have to look at how these maneuvers change the plumbing of the body.
Think of the vascular system a bit like a garden hose. Consider what happens when a patient squats down. Squatting kinks the arteries in the legs, which increases afterload, or resistance, and it suddenly squeezes all that venous blood right back to the heart, which abruptly increases preload, or volume. On the flip side, rapid standing causes blood to pool down in the legs, leading to a sudden decrease in both volume and resistance. And then there's the Valsalva maneuver, which is like bearing down to lift something heavy. That increases pressure in the chest, drastically dropping the amount of blood returning to the heart.
With those maneuvers in mind, let's establish a baseline rule for your typical heart murmurs, something like aortic stenosis. Aortic stenosis happens when the aortic valve gets stiff and narrowed. Because a murmur is literally just the sound of turbulent blood flow, it makes perfect sense that if you push more blood across a narrow valve, the sound is going to get louder. Therefore, when a patient squats, forcing a massive volume of blood back into the heart, the murmur of aortic stenosis noticeably increases in intensity. When they rapidly stand up, dropping that blood volume, the murmur gets much softer. That is your standard hemodynamic logic right there.
So, the crucial point is that not all murmurs play by the rules. In fact, the absolute most vital diagnostic use of these bedside maneuvers is identifying the rebels of the murmur world. There are some specific, very dangerous conditions out there that defy standard logic entirely, behaving in the exact opposite way you'd expect when you change the heart's volume. Catching these exceptions? Well, that can literally be life-saving.
The most famous rebel of them all is definitely HOCM, or hypertrophic obstructive cardiomyopathy. This is a genetic condition where the heart muscle is abnormally thick, specifically right there in the septum. Now, unlike a stiff aortic valve, the obstruction in HOCM is dynamic. When the heart has plenty of blood volume, like when a patient squats, the ventricle is stretched wide open. That keeps the obstruction wide, making the murmur softer. But if the patient rapidly stands up, blood volume drops. The ventricle shrinks down, and that thick, hypertrophied muscle gets right in its own way, severely blocking the outflow of blood. Because of that, the murmur of HOCM gets incredibly loud and long when the patient stands up. It's the exact opposite of a standard murmur.
Let's move to and see how this builds with our second famous exception, mitral valve prolapse, or MVP. The mitral valve separates the left atrium from the left ventricle. In MVP, one or both of these leaflets are just redundant and floppy. When the ventricle violently squeezes during systole, instead of holding firm like they should, the valve bows or prolapses backward right into the atrium. This ballooning effect often creates a really sharp, non-ejection click, and it's frequently followed by a murmur as blood leaks backward.
Because MVP is fundamentally a structural issue related to the physical size of the chamber. It reacts in a very unique way to volume changes. Think of it like a balloon on a short string. If the ventricle is completely full of blood, say when a patient squats, it takes much longer for the squeezing ventricle to shrink down to the point where that floppy valve leaflet runs out of slack and snaps backward. So the click and the murmur are delayed, they move away from the first heart sound. But if the patient stands and the blood volume drops, the ventricle starts out smaller. It hits that structural limit much earlier in the heartbeat, causing the click and murmur to happen earlier, shifting them closer to the first heart sound. By just tracking that click with your ears, you are effectively visualizing the changing dimensions of the heart without even picking up an ultrasound probe.
Which brings us to a really profound realization. We've just mapped the pressure of the right atrium just by watching a pulse in the neck. We've timed the precise closure of valves by listening to a single breath, and we've identified complex structural defects just by having a patient stand up and squat down. The bedside exam truly is a masterclass in physiology. So I'll leave you with this to think about. In an age of artificial intelligence, high-resolution MRIs, and pocket ultrasounds, does the clinician's touch, their highly trained eye, and their capacity for physiological deduction remain our most vital diagnostic tool? The technology around us may always be changing, but the incredible mechanics of the human heart are always right there, waiting to be heard. Thank you for joining me on this explainer, and hey, keep listening closely.